Contaminants or bacteremia. My name is Sulisha Prasad, and I present a case of Corynebacterium striatum causing native valve endocarditis. Corynebacterium species are gram-positive bacilli that are native inhabitants of the skin and mucosal membranes. Due to its presence among normal flora, blood cultures positive for Corynebacterium species are often considered to be contaminated and are thusly disregarded. Our case presents a 65-year-old female with a history of hypertension, hypertrophic obstructive cardiomyopathy, paroxysmal atrial fibrillation, heart failure with preserved ejection fraction, and pulmonary artery hypertension, who presented with the complaint of palpitations. In the emergency room, the patient was hypotensive with a blood pressure of 97/65 and was found to be in atrial fibrillation with a rapid ventricular rate of 154. Her labs were notable for a leukocytosis of 18,400, and blood cultures initially obtained grew positive for Corynebacterium striatum. A transthoracic echocardiogram was done, which did not show any vegetations. However, due to the presence of fever, leukocytosis, and bacteremia, there was a high clinical suspicion for endocarditis, and a transesophageal echocardiogram was subsequently obtained, which showed a 1.5 centimeter vegetation on the posterior leaflet of the mitral valve, along with moderate mitral valve regurgitation. Cardiothoracic surgery was then consulted, and patient underwent open mitral valve repair with incision and drainage of the abscess. Pathology confirmed the vegetation encompassing the mitral valve with acute inflammation, necrosis, and granulation tissue, findings all consistent with infectious endocarditis. The patient was treated with intravenous cefepime and vancomycin initially, which was then de-escalated to solely vancomycin for a total of 6 weeks. Figure 1 shows the vegetation and mitral valve specimen obtained in the operating room. Figure 2 shows the vegetation as seen on the mitral valve on transesophageal echocardiogram. The purpose of this case is to enlighten the audience about the emerging presence of Corynebacterium endocarditis. Although any bacteria can cause endocarditis, only 3% occurs due to Corynebacterium, and only 0.2 to 0.4% occur in those with normal heart valves, such as this patient. This bacteria, often thought to have always been a contaminant, is now an increasing cause of nosocomial infections, even in patients who are immunocompetent with native valves and no indwelling catheters. As such, blood cultures for Corynebacterium should always prompt further diagnostic evaluation, as delay in treatment is associated with a 43.4% mortality.